So now we're going to perform a hip examination. And the hip exam really begins with the patient walking in the room or watching them walk down the hallway and assessing their gait. Here we'll begin with them in the standing position, looking at their basic alignment, and also check and see if there's any leg length discrepancy. You can feel the anterior portion of their iliac crest and get a general assessment of where your hands are and whether or not there's a gross leg length discrepancy or pelvic asymmetry. I'll have you turn around and face the other way. In this position also you can check for pelvic symmetry or leg length discrepancy. I also like to do a Trendelenburg test, which is a test of muscle function of the hip abductors by feeling where the iliac crests are and putting your thumbs in the horizontal plane. I'll ask you to stand on your left leg and just bring your right knee up towards the ceiling. Good, and that's a normal test. The normal response when you stand on one leg is for the hip abductors to contract and for the pelvis to rise slightly. So let's do that one more time. On your left leg, right knee up towards the ceiling. Good. And now stand on your right leg and bring your left knee up towards the ceiling. Good. And in both instances, a normal exam with the thumb moving upwards with the unsupported side. I'm going to have you lay down supine for me. Great. When you assess hip pain or hip pathology, one easy way to break it down is assessing structures or problems that present with anterior pain, those that present with lateral pain, and those that present with posterior pain. The first thing with the patient supine is to just assess simple hip flexion range of motion, whether or not it's symmetric with the other side or that this motion causes pain. You can also do combined movements such as flexion with internal rotation or flexion with external rotation, both of these which stress internal structures such as the labrum in the hip joint itself. These maneuvers might be painful if there's intra-articular pathology causing the hip pain. I like to test strength in this position of hip flexion and adduction. With hip flexion, it's just doing a resisted straight leg raise. I'm going to push down and you push up, engaging the hip flexors. I'm also going to bring her leg out a little bit into abduction, and then she'll bring it back in against resistance, testing her hip adductors. Go ahead and pull in. Good. You can palpate some of the hip structures in front, starting with the anterior superior iliac spine, which is the origin of the sartorius muscle. You can also come down a little bit and find the anterior inferior iliac spine, which is the origin of the rectus femoris, and come down further into some of the soft tissues of the hip flexors themselves, and also along the adductor muscles towards their origin on the pubic ramus. Some of the special tests you can do of the hip with the patient in the supine position. There's Faber's test or Patrick's test. Faber stands for flexion, abduction, and external rotation. And then you stress the contralateral hip and knee and assess for pain. Pain on the ipsilateral side suggests hip pathology, and some people with sacroiliac joint problems may have pain on the contralateral side. Other tests you can do in this position is a test for hip flexor flexibility called the Thomas test. I'll have you bring both knees to your chest. Good. And just let one leg down all the way to the table. With normal hip flexor flexibility, you should have the leg lie flat on the table. If there was a tight hip flexor there, the knee would probably be a little bit bent and not reach fully flat on the table. And then of course you can assess it on the other side as well. Good. Let me have you turn on your side and face that way. In the side lying or decubitus position, I'll bring their knees into a little bit of flexion, knees and hips into a little bit of flexion. Not quite that much, just back right about there. Perfect. I'm going to assess the strength again of her hip abductors by just bringing her leg straight out into abduction, slightly behind her. I'm going to push down and you push up real strong. Good. You can also test some of the strength of the external rotators. I'm going to just rotate her knee out with her ankles still together. I'm going to push down and you push up. Good. And then with her relaxed again, palpate structures on the lateral side that might be a source of pain. So beginning with some of the soft tissues along the lateral thigh and proximal IT band, finding this bony prominence, which is the greater trochanter, and deep to the soft tissues around the greater trochanter and slightly posterior to it, the greater trochanter bursa, which can be an area of pain and bursitis, and then more proximal, up along the hip abductors to see if there are tender spots or tender trigger points. Good. I'm going to have you lie prone, assessing some of the posterior structures of the hip. First is just strength of the hip extensors, which are really the gluteal muscles. I'm going to have you hold your leg off the table. I'm going to push down, you push up. Good, assessing for strength. Of course, comparing to the other side. Hold it there strong. Good. Also, while they're prone, especially in our pediatric population, this is a great way to assess symmetric hip range of motion for external and internal rotation. You bring the knees together in the middle. Just let them fall out into internal rotation, assessing for symmetry, and also an external rotation, assessing both of them at the same time, again looking for symmetry and that their motion is within a normal range. We've done inspection, range of motion, strength testing, and palpation, as well as some special tests for the anterior, lateral, and posterior structures of the hip. And this concludes our hip exam. Thank you.